I'll be presenting today's Radiopedia.org case in radiology, uterine leiomyoma. Case courtesy is demonstrated here, and the case link is in the description below. Presentation: we have a 40-year-old female with a history of primary infertility who presents with pain and menorrhagia. Here on hysterosalpingography, we see an abnormal configuration of the uterine cavity with elongation of the lower part as well as the cervix, where its left border is seen splayed over a large soft tissue shadow. We also can appreciate a round filling defect noted in the upper aspect of the uterine cavity, likely secondary to a submucosal mass. We see that there's delayed filling of both fallopian tubes. However, we see that there's normal caliber with immediate contrast spill on the right side, whereas on the left, we see that there is splaying over the aforementioned soft tissue shadow with secondary mild contrast spill via its fimbrial end. Here on MRI, we see that the uterus is markedly enlarged by virtue of an encapsulated large fundal interstitial myometrial lesion corresponding to the hysterosalpingography soft tissue shadow, eliciting heterogeneous, predominantly low T2 signal with the areas of high signal seen within. We can also see adjacent, much smaller myometrial interstitial lesions related to the upper part of the lesion, eliciting a low T2 signal. Uterine leiomyomas are best diagnosed, assessed, and monitored by ultrasound. Pelvic MRI is needed when the fibroid is symptomatic and needs management, since it's the most accurate modality in characterizing the lesions. Submucosal ones can also be assessed by hysteroscopy. The main benefit of hysterosalpingography in fibroids is as a preoperative assessment of the uterine cavity and the site and size of submucosal fibroids. It also helps assess any concomitant tubal affection, especially if the patient seeks fertility, like in this patient. Post-myomectomy hysterosalpingography may also show any residual fibroid or complications of the surgery, such as synechiae.